Okay.
We're live.
Okay. All right. Well, good morning, everyone, and welcome to the first GIC meeting of 2026. So let me wish you, I think we have a couple of more days before we can't do this anymore, but I'd like to wish you a very happy new year, 2026. Feels like just yesterday that we were talking about 2025. So today we have a jam-packed agenda, and I want to introduce you to the commissioners, our board, who are on today. So I'm Valerie Sullivan, I'm chairman. I am joined here by Dana Sullivan, who is our designee from ANF. I'm also joined by Rebecca Butler, our designee from DOI, Division of Insurance. I have Eileen McEnany. I have Jason Silva. I have Anna Sinenko. I have Tamara Davis. I have Toby Schote. I have Bobby Kaplan, who is our vice chair. I have Jane Edmonds, who was the first commissioner to join today. So thank you, Jane, for your time commitment, as always, to all of you. I have Gerzino Garad. I have Kristen Pepin. I have Dean Robinson, and I have Catherine West. Did I miss anybody who joined, Andrew? I'm going to take that as a no. So here we are.
I couldn't get off mute. We're okay.
Yes. So I'm taking it that this is your commissioners here for the day or this meeting. And at this point, I'm going to turn it over to Matt to review our agenda for the day. Thanks, Matt.
Thank you, Madam Chair. Members of the Commission, great to see you. Happy New Year. So we'll do a brief review of our agenda here today. We will have Cameron McBean, our Director of Vendor Management, present the life insurance and long-term disability insurance carrier recommendation, the result of a significant amount of work on the part of our strategy team here at the GIC. And then we'll continue the discussion that we've had over several meetings regarding potential plan design changes for our coming fiscal year 2027. We have some new information and some additional context to present to you, largely in response to commissioners' requests over the last couple of meetings. Just a reminder that we are not voting on plan design today, but we do need to be prepared to make a recommendation to the Commission for your vote at our next meeting on February 12th. So we want to provide you as much information as we can today. So only 2 items, but 2 substantive items.
Indeed, very substantive. So thank you for going over that agenda. Can we also admit Darren, our newest commissioner, into the meeting? I think he is waiting to be announced. So I'd like to also note that Darren Ambler, our newest commissioner, is joining the meeting today. So at this point, I will take a motion to approve the minutes from our December meeting.
So moved.
So I heard Bobby, I heard Jane, I heard Toby. So we are in good shape. So now I'm going to ask Andrew to take roll call. I'm an aye.
Thank you, Madam Chair. Vice Chair Kaplan?
Aye.
Designee Sullivan?
Aye.
Designee Butler?
Aye.
Commissioner Ambler? Who I am not seeing. I'll come back. Commissioner Schote?
Approved.
Commissioner Davis?
Aye.
Commissioner Edmonds?
Aye.
Commissioner Guerin?
Aye.
Commissioner McEnany?
Aye.
Commissioner Pepin?
Aye.
Commissioner Silva?
I was not here, so I'm going to abstain.
Okay. Commissioner Sinenko,
Aye.
Commissioner West,
Aye.
and let me just make sure that I haven't missed anybody who is here.
Were you able to admit Darren?
There's nothing preventing him from joining, so there's no
Okay.
admission.
The motion passes unanimously with one abstention.
All right, thank you, Andrew. And potentially someone can help our newest commissioner get online. Potentially he needs another link. So thank you, Emily, appreciate it. And I know you're doing double duty with Erica not here today. All right, let's move now, Matt, to the substantive part of today's agenda. We're all looking forward to a robust discussion.
Okay, bear with me for just a moment while thank you, Madam Chair. I think we start with our Executive Director's report. Are we? Excellent. Okay, so we've, as always, presented to you with the full report in writing, but I do want to highlight a few items from the report. First, on the budget, during last month's meeting, Jennifer Hewitt, our CFO, shared with the Commission that we are currently tracking a $153 million in known budget exposures in our current fiscal year. This is due to policy decisions made in the creation of the budget and the impact of the need for supplemental funding to close out the year. We are working with the Executive Office of Administration and Finance on the need for a supplemental appropriation that we expect to be filed early this spring. And we will continue to track and refine the underlying details here so that we can have a realistic forecast for the remaining half of the fiscal year. On the municipal side, as commissioners will recall, we're having a very busy year. The deadline has passed in December for municipalities to state their intent to join the GIC. And then since that time, the one-time extension offered to members of the Hampshire County Group Insurance Trust has also expired. That deadline to supply the staff with supporting documents. All told, we have 11 municipalities planning to join the GIC for our coming fiscal year. And our municipal staff, Morgan Simcoe, with the assistance of others, held the first group onboarding meeting with these entities. And we are working with each of them to draft communications to the members that will be joining from each of those municipalities, work with them to collect data, all the work and support for the municipalities that needs to get done to prepare for annual enrollment. I would say finally on the municipal front, members of the GIC staff, myself included, are looking forward to participating in the Mass Municipal Association conference late next week. We'll have a table where we'll be sharing information and engaging with interested municipalities. So that is the municipal update. We had, since we last met in December, we have launched our VITA program to manage our GLP-1 spend on January 1st. And during the December commission meeting, we had a number of questions from commissioners about communications to our members about their program. The written report contains a comprehensive breakdown of all of those efforts that have already occurred and some that are planned for the coming weeks and months. So Briefly, though, 2 weeks leading up to the implementation date of January 1st, all members who are currently utilizing GLP-1s for weight loss received a notification that they could enroll in Vita starting on January 1st. We've also added information to the GIC website, and we have a landing page on the Vita website. And I just want to note or remind commissioners that there is a 90-day grace period for members to give them ample time to enroll and complete Vita's requirements. So this is all happening as we speak. Members have begun registering for Vita, begun selecting the programs that Vita offers, and they're beginning the steps in the process. So again, you can see more statistics about this in the written report. Finally, on Vita, we continue to work very closely with the Vita team weekly to discuss additional communications efforts and address member questions and concerns and to review enrollment data. So that's the update on Vita. I will just add one item that is not in the written report because it's late breaking from yesterday. The Healy-Driscoll administration made an announcement that they are forming a healthcare affordability working group with an ambitious charge to develop a wide range of options for solutions to rising healthcare costs. As we have talked about a good deal over the last several years, it's really broad market reforms that will be needed to substantially move the needle on affordability for the GIC and for all others who purchase insurance for employees. So I am a member of that working group. The expectation is that we'll be getting to work very quickly, and I'll continue to provide updates to the commission as that work proceeds. With that, I am happy to pause and take questions on any of that.
Yeah, I don't see any. Oh, here we go.
I answer questions. I have questions.
Yeah, sure. Go ahead, Toby.
Two things, Matt. One is, what's the difference between the working group and the Health Policy Commission? Isn't that what they're supposed to do?
So the Health Policy Commission will participate as a member of the working group and bring their areas of expertise to the working group. And I think that, so all of the work that the HPC has done to develop a set of recommendations, and really more than anything, their understanding and knowledge and data about how the market is performing, that will all be part of the working group.
Okay.
I would say what this is designed to be is a multi-stakeholder working group. So it's not one agency. It's and it does include, so it includes a number of different state agencies that have touch points on healthcare and healthcare affordability, but will include a variety of industry interests as well. That's my understanding.
Are the provider groups in it, or their representatives?
I believe they are, yes.
Okay. Cool. Next question. I'll reserve comments on that last one. But next question. Any feedback from the people who've engaged with Vita members? Anything you can kind of enlighten us with? I know it hasn't been going very long, but some people have engaged with it.
Yeah, I think I would defer this to members of my team who have who are really managing that work day to day with Vita. Would that be Cameron?
Sure, I'm happy to speak on the feedback we've received so far. Unfortunately, because this is an extra hoop to jump through, many folks are unhappy to, we've heard feedback that, such as you're taking care out of my local doctor and, handing it off to this other company. And unfortunately, we, our consistent response has to be that this is the best option we have available to maintain any level of access for these medications. And that's just the market environment we're in right now.
So for people who have kind of gotten over the hurdle of they have to go through another step, that are engaging with Vita, I'm just trying to get a sense of how how they are to work with, at the member level. I mean, are they responsive? Is it effective? Is people think they're getting good advice? Because that's really what a lot of this is about. Or is it premature?
I think it's premature, Toby. It's only been 15 days since we've launched the program.
Okay.
But those are the sorts of questions, frankly, that we want to be able to answer for you as we get a little bit further into the program.
Okay, thank you.
Hey, Eileen, do you want to go ahead and ask a question?
Sure.
And then
So,
Jane, you're teed up.
So with respect to the working group, Matt, a couple of things. I know the governor said she wanted the results yesterday, and I commend her for that. But in my experience, working groups of this size don't even get going for a month or two. And so I doubt that there'll be any kind of substantive work done by June, which is what she was hoping. And the other thing I would say is I hope that your participation on this doesn't slow down the work that the GIC has been doing, because I think we've had like a head start on a lot of these conversations and things. And in fact, I think that you should actually be a leader on this working group, because to Toby's point, if you look at who's on it, it is most of the stakeholders and it's a lot of providers, and not enough, in my opinion, purchases of commercial insurance. And this is about affordability. And so just want to emphasize, I hope that you make that point of view loud and clear, and then we take a lead on these issues. Thanks.
100% agree, and I intend to do that.
Yeah, thanks. Go ahead, Jane.
I guess my issue is, bottom line issue is that if we're focusing original cost assumptions on injectable formulations, now with the pill, doesn't that shift the cost dynamics? And I'd be interested to know from staff what the costs are related to the pill as opposed to injectable formulations. In other words, in my own opinion, it seems like a key policy issue for us is that we may already be outdated in terms of what's happened in the marketplace. So if you could comment on that, Matt?
Yeah, happy to. And we'll talk a little bit more about GLP-1s in a focused way a little later in the meeting. But I can tell you that, so yes, you are correct. The FDA has approved the pill form of Wegovy, the oral form of Wegovy. I can tell you that it is not less expensive than the injectable form. It is priced comparably to the injectable form. We do anticipate a shift of members who are currently taking the injectable to the oral pill form. We also fully anticipate that utilization of GLP-1s will increase overall. I think as Commissioner Ambler mentioned in the last meeting, those who are perhaps reluctant or uneasy about a weekly injection of a drug would overcome that and be new utilizers of the drug with the pill form. So that is an area of concern for us as it relates to our spending trend on GLP-1s for weight loss. But again, we'll come back to that a little bit later in the commission in the meeting, but I hope that answers your question.
Well, partly. I mean, as we all know, this whole topic is very, very complicated. So, there are many, many questions that go through my mind, such as, what's the expected price differential of the next 2 or 3 years when you talk about costs? And so I'd be interested to know what that looks like. Or are we factoring in avoided costs from diabetes and from cardiovascular complications? How does that factor into costs? And what it sounds like you're saying is that a pill first coverage strategy isn't going to change the meaningfully any kind of FY27 projections. Is that what you're saying?
Well, what I would say is I am concerned that it will increase and potentially significantly increase our spending on these drugs.
Okay. All right.
But I would say, and to your other point, Jane, about reduced costs as a result of weight loss, those we expect will be real over time, but are unlikely to present in the near term, right? So as is often the case with the introduction of a new prescription drug, you face the very significant upfront cost with the expectation and hope that over time you will have the benefits of health and wellness, but also reduced spending on other services like, cardiovascular disease and diabetes and other conditions that can be addressed with weight loss and ameliorated with weight loss. So it's just going to take some time. I will just note, so your question was about the impact on our potential spending in FY27. I even am concerned about the impact in the remainder of fiscal year 26, because these are just coming into the market now. So we're actually spending a lot of time on all of these issues with CVS to try to navigate this in the best way that we can.
Thank you, Matt.
You bet.
So I know, Bobby, you've been very patient. So why don't you go ahead and ask your question, and then Darren, and then Anna.
Thank you, Valerie. So I have a couple of questions. Well, first of all, regarding the working group, there was an article in today's Globe regarding the working group, and it might be inaccurate, but it did mention that some of what they're looking at would be the authorizations, but that it would not apply to self-insured employers. And I was curious about whether, some of what the group is going to be looking at will not apply to us or to the GIC.
So there were two initiatives announced yesterday. One was the affordability working group. The other, somewhat related, was a new set of regulations that are coming from the Division of Insurance. You are correct that those are for the fully insured state-regulated marketplace and do not apply to self-insured plans directly. So we will be evaluating those regulations when they come out. But I don't see that work sort of overlapping or interacting a whole lot with the affordability working group. Hope that's helpful.
Okay. Yes, it is. Thanks. And sorry. I have another, or I just wanted to comment, or to echo sort of what Cameron reported regarding Vita. I know it's early. It's only been 2 weeks since they launched, but I will say from the member perspective, people are reporting that it's very difficult, that they feel. I spoke to 3 people last night who told me that they think they're when they are on the app and that it's mostly AI, and they have to.
I think we lost Bobby.
No. Sorry. So people are reporting they think they're speaking to a chatbot, mostly AI, and that that it's very difficult when they have to upload medical records. They're concerned about the data, what's happening with their data when they have to submit their medical records. Where is it being stored? What is the security? People are very concerned about that. What's going to happen to all their, medical information, and that they have to resend multiple times the same documents over and over. And a lot of people can't seem to speak to an actual person. And they're concerned. And one person reported they actually did speak to a human who was basically in a call center in Texas. And so when they asked about their medical records and what was going to happen, they didn't have a response. They didn't receive a response. So my question is, what is happening with the medical records? Are we sure that that medical information is protected? Where is it being stored? And people are also complaining, and we're told by some VITA agents that they do not communicate with the members' primary care. So people have gone to labs because one of the requirements is to have their lab work done. And I'm hearing that some people have a $40 copay, others have a $100 copay for the labs. And there are only 2 labs, I guess, that VITA is instructing people to go to, Quest and LabCorp, to have their blood work done, but their primary care is not involved in this process. And it's concerning to a lot of people because there's no communication, I'm told. So I know it's very early and hopefully, things will resolve, but I'd like to know, I think we'd all like to know, what about their health information? How is it being protected? How do we know it's protected? And so those are
Yeah,
questions.
I can answer at least the health protection piece if you want, Matt.
Yeah, go ahead, Andrew.
Yeah.
Just keep it brief and then we'll move on.
Yeah, VITA, it falls under our HIPAA requirements. Under the BAA we have through CVS. But in addition to that, I have already inquired, because I know this is an issue for members, that with their legal department, and I am awaiting a full copy of their privacy policies and some of the answers to the questions you raised, as where it's stored, et cetera. And I can follow up with that in the future.
Yeah. So
so thanks, Andrew. I appreciate that. Bobby, I'm so glad that you raised these issues. Potentially, just to keep us moving forward, this is something that we can take offline or report back next meeting, because it's a very important issue, and I'm glad you raised it for our members. But we do have to move, or we're not going to cover the substantive part of our meeting. Anna, you've been patient. Why don't you go ahead and answer your question, if you don't mind being brief and effective here?
Yes, sorry. Thank you for giving me the chance to just add a comment here, which is that I just wanted to respond to Matt and Jane's quick discussion around cost savings from the health effects of people using GLP-1s. So I'm just not sure it'll come up again. And we have actually, this is pretty new research and evidence that's come out just in the last week or so of 2 studies using real world data to track patients and their experiences on GLP-1s over time, because the prior evidence on this was really from smaller clinical trials or simulations. And there's no evidence that the GLP-1s are leading to cost savings, those offsets that we were hoping for. It does look like there's health effects, as we expected. People have better blood sugar control, they do lose weight, but in terms of other utilization and cost savings, it's not materializing. And I just think that's important to understand in the discussion today.
All right, thanks, Anna. That is good. And I would love to see that study, or maybe we can take it offline. So thank you. All right, Matt, one comment I want to make is that I appreciate that there's so much detailed feedback on the VITA program in your executive director report. Since there was so much discussion around VITA and it was in the report, potentially knowing how our commissioners wanted to hear that, you might have just popped that slide up. So noted for the next meeting what commissioners want to hear about, but you did do a really nice job putting that data in the executive director's report. So thank you. So let's move to the next agenda item, please.
So I think here just do a brief update. I'll be very brief here. So we already know what we're here for today, and on our February 12th meeting, our vote on plan design, and as Cameron will note his presentation, a vote on our new FSA administrator. On our 26th meeting is our final vote in preparation for our coming fiscal year, where we vote on rates, and additionally, we will have an apparent successful bidder for our pharmacy consultant to assist us on our PBM reprocurement. So lots of work happening on the procurement side. And then you'll see no meeting scheduled for March. April is TBD at this point. And then we'll round out the end of the fiscal year with our out-of-pocket report and our recap on annual enrollment.
Do you have the next slide here?
Yeah, just a reminder, I think we've shared this with the commission already in the past. We have our public information sessions set for the week after next. Commissioners are invited to participate if you can get to one, just to experience what the member feedback is. We would encourage that. These will all be virtual again this year, as we've had a great deal of success and much higher engagement through these than we had in in-person sessions, and we will continue to answer questions live through our text thread, the chat thread, but also verbally. So just a note that those are coming.
All right, thank you. I would appreciate it if all commissioners joined at least one. I think it will inform your thinking about how our constituents think about the GIC. So thanks for making these so accessible.
All right, with that, thank you, Madam Chair. Hand it over to Cameron to walk through our Life and LTD procurement recommendation.
All right, thank you, Matt. Thank you, commissioners. If we can move on to the next slide, please. As Matt mentioned, I'll be walking you through our final recommendation as a result of the Life and LTD carrier procurement that has just concluded. We are also in the final stages of interviews for our FSA administrator, which we took out to bid a couple of years early. And then we are also going to be interviewing finalists in the very near future for our pharmacy consultant contract, so that we can take the PBM contracts out to bid over the course of the upcoming 2026 calendar year. So as a brief overview of the Life and LTD procurement process, we were advised by the Alero Group, formerly known as Boston Benefit Partners. They also assisted us on the last procurement. We had bids received from several major carriers, most of which have direct experience working with the GIC previously. And fortunately, we went into this procurement without any major concerning gaps in coverage or major benefit design changes that we were seeking to make, because of the recent increase, thanks to the legislature, for are on the basic life benefit, the recent doubling of from 5,000 to 10,000. Next slide, please. So having said all that, we went through the initial threshold review phase. We settled on 2 finalists for interviews. These both offered a combined offering for both life and LTD. Most of our bids were for both products. Securian was our only bidder who only submitted a bid for one of the products, and that was life and life and AD&D. So our finalists were MetLife, who's the incumbent, and the Hartford. And the final results after the interviews and BAFOs, the team, along with our consultants, selected to renew our contracts with MetLife as our recommendation. We got some rate relief, particularly for the active membership on the life premiums. So we were happy with the results. We've got the option for an open enrollment on the LTD if we choose to do so sometime in the future over the life of this contract. We may also, at some point in the future, we didn't want to make a change since there's likely to be a fair amount of changes we're going to have to communicate on the medical insurance side. But one of the long-term plans we may want to make is an adjustment on the long-term disability to match up with the paid family medical leave benefits available to state employees or to workers in the state of Massachusetts, not just state employees. That would offer some rate relief, but that's something we can do. MetLife has agreed to work with us at any point, should we want to make that change. But it's not anything we're in a rush to do, but it's an option that we've got. So that's one of the reasons why we were happy to settle on this recommendation and work with Met in a long time. Commissioner Kaplan, I believe you've got a question.
Yes, Cameron, thanks. What are the changes for members, like directly for LTD in particular?
No changes.
No changes.
LTD.
Okay.
Yeah, we're making no benefit design changes. A number of active employees will see a small decrease in their life and AD&D premiums, but that is it. We do have some RMTs, the retired municipal teachers. Those have capped and set life amounts that are, not subject to fluctuation. There's a little bit of an increase there. And that is a risk adjustment that we were comfortable with MetLife making.
Thank you. And this is a 3-year contract? Is that
3-year with 2 1-year options to renew. Yep.
Okay.
Our standard format.
Thanks, Cameron.
You're very welcome. Any other questions on this procurement before we move on to the vote slide?
Oh, I do.
Yeah.
I have sorry.
No, go ahead, Bobby.
I had another quick question regarding the the FSA.
Mm-hmm. We're still in an active procurement, so there's not a lot of discussion that we can have about the procurement itself.
No, I know that. My question actually was not related to the procurement. It was whether you knew at this time whether that's going to be increased, the amount, the cap.
The benefit amounts? Yes. Because the IRS announces those the new cap limits usually at the end of a calendar year. So November or December, we find out what the next year's limits are going to be. Our plans run on the fiscal year basis. Right. So the fiscal 27 caps for next year will go up to account for the recent increases in the IRS. We don't
Oh.
make the changes mid-year during the plan year.
No, I know that, but I was curious if you knew what that cap was going to be for FY 27, if you knew yet.
The IRS is releasing. I don't have it off the top of my head.
Oh, okay. All right. Thank you. Thanks. Would you be able to have that for the
Oh,
next?
absolutely. And it'll be included in the benefit guides for fiscal 27.
Okay. Thank you.
You're welcome.
So thank you, Bobby. I don't see any other questions. Cameron, could you just briefly chat around, if the maximum number of points is 100, while it's exciting that MetLife, our incumbent, has scored the highest and gave us some rate relief. Just curious, there's a gap of 20 points plus, even to win. So, B minus, C plus was never a grade that any of us was, cheering about.
Yeah, a lot of that has to do with two categories in particular. The SDP, the Supplier Diversity Program. MetLife got a pretty good score from that perspective. But you'll see out of the where it says the BAFO financial result in that chart on the right, that's the scoring for the pricing. So the way our consultants handled that is the scores are based on a deviation from the mean. So an average of everything that was submitted, and then how far away you get up or down, determines your score. So the highest score we had in the cost proposal using that methodology didn't even get to 20. So that's where some of those lower values may make it seem, I would say, artificially so, like it may not, they may not be a high scoring performer. Like, say, out of looking at the interviews, MetLife did great, Hartford did very well as well. I am not concerned. It's more about the scoring relative to each other.
Yeah.
Than the total value.
All right. Well, just no need to comment. But if their BAFO is a little low, maybe from a negotiating perspective, you can get us better rates because we are the GIC. So let's keep moving. I think we need a motion here.
Yep. Oh, and while we were discussing Commissioner Kaplan, the FSA limit for 2026, which will be our fiscal year 27 plan, is $3,400 on the medical side.
Thank you.
There we go. Look at what service to you, Bobby. All right, let's, at this point, I'll entertain a motion to approve us contracting with MetLife, apparent successful bidder. We're still in the negotiation process. Cameron might try to get us some additional basis points, but I'll entertain a motion to approve this by the procurement team.
So moved.
Bobby is primary. Second?
Second.
Jason is second. So let's take a roll call. Andrew, I'm an aye.
Thank you, Chair. Vice Chair Kaplan,
Aye.
Designee Sullivan,
Aye.
Designee Butler,
Aye.
Commissioner Ambler,
Aye.
Commissioner Choate,
Yes.
Commissioner Davis,
Aye.
Commissioner Edmonds,
Aye.
Commissioner Garon,
Aye.
Commissioner McEnany,
Aye.
Commissioner Peppin,
Aye.
Commissioner Robinson,
Aye.
Commissioner Silva,
Yes.
Commissioner Sinenko,
Aye.
and Commissioner West.
Catherine? Did we lose her?
Well, the vote
What's going
passes
on?
unanimously of those voting.
Okay, great. All right. Thank you. Thank you, everyone. And thank you, Alera. And let's try to get a little bit better costs. We're under the gun on budget. All right, let's keep moving.
All right, let's move on to our plan design discussion. Again, just a reminder that, are we on the, why don't we move to the next slide, the objectives of the discussion. So just a reminder at the outset that that today is for discussion, not a vote, which will happen at our February 12th meeting. Over the last few meetings, we've heard from ANF about the state's challenging fiscal picture and the urgency of taking steps to reduce our projected spending to align with this emerging reality. We've also been previewing with commissioners the various tools at our disposal to create that alignment with a series of plan design changes and related initiatives. Today, we intend to dig into some more detail, both on the budget exercise that ANF has given us and how each of the proposed plan design changes get us there. So we'll be providing some additional data, some additional context on cost savings for each proposal and some disruption analysis about how it will impact our members. So that's the objective today. And so on the next slide, the graphic on the top here will look familiar from our December meeting, where it lays out what our projected increase in spend is on a status quo basis before any changes. And you'll see here again, it does exist in a range. We will be narrowing down that range and providing, as we do our more due diligence leading up to our rate vote, but we do expect still to land at this point in the mid-range here with a 10.9% increase. This translates into about a $170 million increase in the GIC's request into the state budget. So as we have discussed as a group, this is an aggressive target. We've been given an aggressive target from ANF, and that target is to cut essentially $120 million out of our spend that would be directed towards keeping us to an increase of about $50 million. So with that as context, again, today we will walk through the plan design changes and provide you that additional data. Move to the next slide. So this slide we wanted to provide for context. So the way our statute, Chapter 32A, is written, as you all know, the GIC's plan design, which again directly affects our budget, is in the hands of the commission. And funding for this benefit is in the hands of the governor and the legislature through the state budget that's enacted, and on occasion through supplemental appropriations over the course of the year. But the benefits are really in your hands, and your obligation, as you see in the top provision here, is to consider the interests of our members and also the Commonwealth in the form of the budget. So in this year, clearly those two considerations create some tension. So the obligation for the commission really is to try to find the right balance. And our recommendation, the proposals here give us the opportunity to find that right balance. I will say, this happens as we continue to look for fundamental reform efforts through the governor's working group and elsewhere. So with that, I'm happy to hand it over to Margaret. So she's going to start with some slides that we pulled forward from the out-of-pocket report that we presented, Lauren Makashima presented back in May, that illustrate the relative benefit levels of the GIC and how they compare to the market. Margaret?
Great. Thanks, Matt. Could we move to the next slide, please? All right, to bring some context to this discussion, I'm going to quickly walk through a few slides from last year's out-of-pocket report. The slide before you shows the Commonwealth has paid for almost 92% of GIC members' medical costs in fiscal year 22 through 24. This is the most recent data available, and I expect the FY25 numbers to be similar. Next slide. This slide is from CHIA, and it shows medical cost coverage in different Massachusetts market sectors. In the jumbo market, the blue bar, second from the right, 89% of medical costs are covered by employers. Comparing this to GIC's medical cost at 91.6 in FY24, you see that GIC provides slightly more coverage of medical costs than its peers. Next slide, please. Another slide from last year's report. On the left, we see members' out-of-pocket costs on a per member per month basis. And on the right, we see GIC paid amounts on a per member per month basis. What's important here for this conversation is the slope of these lines. On the member side, out-of-pocket PMPM trend is relatively flat, with a roughly $3 medical cost increase between FY22 and 24, and a small decline in pharmacy out-of-pocket costs in the same time period. Compare this to the trend on the right side of the slide, and we see a sharper increase in trend in GIC paid amounts for both medical and pharmacy claim costs. These data demonstrate that while healthcare costs have been growing over the last 3 years, GIC has been absorbing a greater portion of those costs than members. Next slide, please. Finally, this slide contextualizes GIC member out-of-pocket costs in the Massachusetts market. As of 2023, the latest year for which we have this data, we can see GIC members' cost share at $49 PMPM versus $61 in the jumbo market. Through the last 4 slides, I've shown data on how increasing healthcare costs have been split between members in the Commonwealth and how these splits compare to the Massachusetts market more broadly. In aggregate, GIC has absorbed a greater portion of rising healthcare costs than our members. Our plans have also have lower aggregate cost sharing than other plans in our market sector. Before we move on to proposed plan design changes, I also want to provide some additional context around our healthcare benefits, more from a member perspective rather than just the market perspective. Health benefits are part of an employee's total compensation package, which also include pension and salary. Most, but not all, of the plan design changes below represent a cost shift to members, or a reduction in their total compensation. This can be difficult to absorb in a time of high inflation, particularly for lower income members with little discretionary income. Next slide. You will recognize these slides from prior commission meetings. We've added a few new numbers to this benefit summary. On each row, you'll see public sector benchmarks to compare our benefit to, the disruption analysis showing the number of members that a benefit cut would affect, the net budget impact, which is the amount of money that would offset the $120 million that ANF needs from us, and the reduction of the FY27 rate increase that eliminating or changing a benefit would provide. First, on this slide, I'm going to walk through 2 contribution ratio changes that are being pursued in the legislature and that the commission will not be voting on, but we want you to be aware of these. The top row here shows the dental contribution ratio, which is currently at 15%, and the proposal is to change this contribution rate to 25. Second row proposes raising the health insurance contribution rate for all employees to 25%. Next slide, please. This contribution ratio does require a commission vote. A surviving spouse currently pays 10% of the premium. This proposal would increase the spouse's contribution ratio to match that of the deceased spouse, affecting about 8,100 members. Let's move to the next slide. Now we're looking at proposed benefit design changes. Again, you've seen these before at the last few meetings. Changes we've made to these benefits since the last meeting are grayed out with a strike through, like you see on the second row. This slide has changes that are pretty small in terms of our rate reduction. For example, in the third row, increasing the ER copay from 100 to 150 has an impact of reducing our FY27 rate increase by about 1/10 of a point. So taking our midpoint aggregate increase of 10.9%, we would see that increase reduced to 10.8% should the commission vote for this benefit change. The first row holds another benefit change with a modest impact on rates. Increasing the urgent care copay to $30 brings us in line with the public benchmark. In the second row, the 3 free telehealth mental health benefits is no longer a benefit that we would like to bring to the vote at the next meeting. Keeping this benefit supports our efforts to increase access to behavioral health services. In row 4, the proposal is to eliminate hearing aid coverage that is above the state mandatory minimum, which will affect about 2,500 members and reduce the upcoming premium increase by about 1/10 of a point. Next slide. Rows 1 and 2 here are related. At the December meeting, we discussed increasing out-of-network coinsurance from 20% to 40%, which is in line with the benchmark. We decided to carve out behavioral health from this coinsurance increase, as not only is there a shortage of therapists, but many therapists do not contract with health plans. The proposal now is in row 1 to increase coinsurance to 40% for med-surg only, as members broadly are often able to find an in-network alternative. The last row on the slide shows changes for the GIC's out-of-network reimbursement rate for Massachusetts providers, lowering it to 100% of Medicare. This is specific to Massachusetts, as we have balanced billing protection for our members, so providers can't charge our members for the difference. It's also an incentive for providers to come in network. Next slide, please. On row 1, we have proposed increases in copays for PCPs and specialists. The proposal raises PCP Tier 1 copays from $10 to $15, which is still below the benchmark. As you are aware, we tier providers. For PCPs, the increase to Tier 2 is $10, and to Tier 3, it's $15, with the hope that some steerage to higher tier providers may result. A similar logic applies to specialist copay increases, where Tier 1 specialist copays would increase by $5 to meet the benchmark. Tier 2 is up $10 to $70, and Tier 3 is up $15 to $90. A note about these savings projections here. What we have listed is the savings projections that do not assume any behavioral changes. There is, if our members do move as a result of, for example, the specialist copay being at 90 and members wanting to find a cheaper alternative, we think of that as a behavior change, and there are additional savings that would be associated with that. So for the PCP copay changes, as well as the specialist copay changes combined, if you factor in migration assumptions, behavioral changes, we may see an additional $9 million in savings. Finally, on this slide, we have proposed increases to deductibles, with broad plans changing from $500 to $700 for individuals and $1,000 to $1,500 for families. Limited networks would change from $400 to $650 individual and from $800 to $1,300 family. We grayed out the lower increase to deductibles in the last row on this slide because we are still short of the $120 million target and need to consider a higher deductible to meet the ANF target. Next slide. Finally, we have proposed changes to the pharmacy benefit. First is the Prudent RX program offered through CVS. The program lowers copays for members to zero and saves the GIC almost $14 million. This is accomplished by applying a manufacturer coupon behind the scenes on the CVS side for specialty drugs. The coupons reduce our members' copay, and the rest of the coupon savings are split between CVS and GIC, with GIC projected to receive $14 million. Members must enroll in this program, and if they don't, their copays would increase substantially, which is why CVS conducts an extensive outreach campaign to members in support of enrollment in this program. Second, we have the proposal to eliminate GLP-1 coverage for weight loss. Earlier this year, we engaged Vita to help save money in this space, but covering this drug remains expensive. Dropping coverage would save $46 million in the next fiscal year. As you've heard me say before, GLP-1s are highly effective, helping people lose considerable weight and reducing chances of developing conditions associated with obesity, many of which are high prevalence in the BIPOC community. Continuing coverage directly supports our goal of reducing health disparities. When people stop taking this drug, within about 18 months, the weight is returned and all cardiometabolic gains from the drug are gone. Some members would be able to maintain coverage by paying out of pocket, but of course the drug is very expensive, so it would be higher income members with discretionary income who could afford to stay on the GLP-1. Next slide. Let's now put all of these benefit changes in the context of our FY27 aggregate rate increase. At the December commission meeting, we previewed a status quo increase in the range of 8 to 12%. If all of the benefit changes just discussed are adopted, we can expect 4.9% reduction in that rate increase, putting the new aggregate increase range at 4% on the low end and 8% on the high end. Next slide. Thanks. And finally, here's a graph showing how the adoption of each proposed benefit affects our projected rates. You can get a sense here of the relative magnitude of savings of each of the benefit cuts and how their passage would lower our FY27 rate increase. Now I'm going to turn the presentation back over to Matt to summarize what we just walked through.
Thank you, Margaret. So clearly, many of these proposals are increases to member cost sharing, something that we as an organization have avoided doing now for 8 years. We've done that as a strategic decision, and we know that these steps do not address underlying drivers of rising healthcare costs. But given the budget challenge this year, these changes are necessary to achieve alignment with the governor's coming budget proposal. Even with these changes, it is important to note that the GIC's plan design will still compare favorably from a member perspective to much of the rest of the market, and are not unreasonable, therefore, for the commission to consider. We also propose, of course, several initiatives that Margaret walked through that bring us substantial savings with limited or no impact to members. We have the out-of-network payment structures and the Prudent RX copay maximizer program, and we're proposing an adjustment to the surviving spouse contribution ratio, which has its logic and is also not, in my view, unreasonable to consider. And then we propose reductions in benefits in 2 specific areas, on hearing aids and on GLP-1s to treat obesity. So this, I will just note for some commissioners who we previewed some of these materials with earlier this week, you'll note that that is a change that we've made even just over the last couple of days as we have been continuing to evaluate some different options on GLP-1s. But GLP-1s clearly requires some additional consideration. I think our discussions about Prudent RX are a real reflection of that. So if we can go to the next slide where we can dig in a little bit more on GLP-1s. So as Margaret indicated, these are highly effective drugs. We know the cost burden that this represents to the GIC is very substantial. So that is the largest cost savings measure that we propose to you today. We know these drugs bring enormous benefits, and the potential of foregone costs, of course, as Commissioner Seneko pointed out, is uncertain. But we know it increases our members' health and well-being over the long term. I would say, just to emphasize, this is a very dynamic space right now. And if you just consider our members' experience in using these drugs over the last year, if you were a member who was prescribed Zepbound last spring, you were required to move to Wegovy, except in very rare circumstances. That was a substantial change and disruption to our members. We implemented the VITA program mid-year, again, driven by some budget necessities, and we have already discussed the disruption that brings to our members. So we do not propose lightly here the discontinuation of coverage for the coming plan year with all of that context in mind. I think so. We've implemented VITA. We've already discussed the introduction of the pill form of Wegovy that introduces new and challenging dynamics. We are learning on a regular basis about some potential new options that are available to us from CVS. There's the potential of adding a higher member copay onto these drugs as well. So this is it's a very rapidly changing area with a lot of uncertainty. So what we wanted to do on GLP-1s is to get some feedback from the commission on how you'd like to see us proceed as we prepare for our February 12th meeting and votes. And then if you have a specific question, Bobby, I'll take it. If you have a comment, I'm just about done with the slides.
No, I had a question. I
Yep.
just wanted to know if all of these recommendations were, implemented, what the dollar savings would be. Would it be the 120 million?
That's the next slide. That's
Oh,
exactly
okay,
what we have in the
sorry.
finals. That's okay. That's okay. It's a
Okay,
great question,
thanks.
which we've tried to anticipate here. Toby,
Thanks.
if folks have specific questions on this, I'm happy to take them, or we can hold them.
Go ahead and finish, Matt.
Okay, Jane, I see your hand.
Hold on. I hate to sound like a broken record, but I'm deeply concerned that we're singling out GLP-1 medications, not because they're ineffective or inappropriate, but because they're visible and they're expensive and they're frankly politically inconvenient. And I just don't think that this is cost containment. It's cost avoidance in the short term and cost escalation in the longer term. And so I continue to be very concerned that just because this is a high cost ticket item, that we're focusing on too easy solutions and just wanting to try to eliminate coverage for it. And it feels like a slippery slope too, because the way I look at it is that if we eliminate coverage for something that has high costs, such as this does for what has been presented as a small percentage of the larger population we serve, and has a definite negative impact on I might add, people of color, which obviously is a great concern. I just think it's a slippery slope. What if tomorrow there's a high cost, expensive drug that to fight cancer or something else? Are we going to want to eliminate that kind of coverage because it just costs too much? So I guess in principle, as we're thinking about what we're talking about I'm still very opposed to the idea of eliminating coverage across the board. And I know we haven't yet even got to that, but since I have the platform, as I looked at the presentation that Margaret so brilliantly offered, and thank you for that, I thought it was a great presentation. But when you talk about increasing premium contributions for surviving spouses, frankly, I think that's an option that needs to be removed from our consideration, period. I don't even think we should have that on the list because the policies existed for many, many years, I'm not sure how many, to protect people who have lost a spouse and often face financial hardship. And shifting additional costs like that onto people who are already in a vulnerable position, I think represents a fundamental break from longstanding Commonwealth values. So on both of those scores, I just have a lot of concern about what we're about to do.
Thank you,
Yeah.
Jane. I see
Yeah,
hands.
I see hands up too, Matt. Are you finished with your presentation, or did you have one more slide that
It'll
you'd
take
like
me
to?
30 seconds on the final slide, and then we can just open it wide open. Yeah.
Yeah, let's do that and summarize, and then I will be asking for the input because that is the purpose of this topic.
Thank you, Madam Chair. So here we wanted to keep commissioners from having to do math on the fly, which I always get wrong when I do. So what we lay out here are the numbers that relate to what we've presented to you, and what some of the different scenarios are, and what they would produce in terms of our premiums and the A&F budget target. You'll see here the status quo of doing nothing, the adoption of all recommendations as proposed would get us essentially to the budget target and have an increase of 6%. And if we adopt all of these except for GLP-1 elimination, that leaves just short of a $50 million gap with the state budget and a premium increase of 8.4%. So with that, happy to stop and listen. I would say we welcome any and all feedback, and we want to be able to make sure that we structure the discussion in our February meeting in a way that is helpful and efficient. So if you have thoughts on that today or at any time subsequent, we'd be eager to hear your thoughts on that.
Yeah, thank you, Matt. So hands went up so quickly. Dean, I saw yours first, so why don't you go ahead and take the floor?
Okay.
And then I'm going to go to Eileen because I know she's got a hard stop at 10. So thank you, Dean.
Okay, one quick comment on the projection side of the equation. So the budget, I just want to say that the budget target gap of 120 million is arguably a moving target, by which I mean we've heard from the governor's office that this figure amounts from differences in rising healthcare costs on one hand and projected revenues on the other. But closing that potential gap is ultimately a matter of government policy or legislation. The state recently and appropriately directed something like $250,000 to cover expiring subsidies on the for the Affordable Care Act.
$250 million. Yeah.
Yeah. Sorry, what did I say? $250 million. The next point is it goes more to equity, and this is piggybacking on what Commissioner Edmonds says, that the burden of chronic disease that we're treating with GLP-1, obesity, various kinds of metabolic disease, from an intersectional standpoint, hits not just people of color more, it hits people of lower socioeconomic status more. So my members that make the least amount of money, that are wage employees, for example, are already carrying a higher burden of chronic disease. So to eliminate GLP-1 coverage is deeply problematic and to me deeply, profoundly inequitable because the burden falls on lower socioeconomic status members in the first place, who also have the fewest financial resources in terms of seeking alternatives on the market. That's what I wanted to say.
Oh, thank you, Dean. Go ahead, Eileen.
Sorry about that. Thank you. So I guess I listened to Commissioner Edmonds' comments about GLP-1s with a great deal of interest, and it was a way to think about it that I hadn't before. So I appreciate that, and I appreciate the thoughtfulness of all of these options in the comments. I guess my overall reaction is a lot of this has to do with benefit design change. And I do just wonder, like, are we looking at ways to purchase healthcare differently so that the costs aren't automatically an increase of 10.9%? And I know I asked this a few meetings ago, but there are other states where the reimbursement rate is set at a percentage of Medicare, for instance, or I guess I just will reiterate my request that we explore ways we pay for healthcare to reduce cost in addition to the benefits that we purchase.
Yeah, I'll just make a very brief comment, Eileen. So I think you weren't able to join us for part of the discussion in our December meeting where we actually walked through a presentation on some of those steps that other states are taking and the work that we have underway to evaluate those and potentially add them to our portfolio. And I would say on the pharmacy side, you didn't ask about that specifically, but clearly this is an area, even GLP-1s notwithstanding, which is a big caveat, is an area where we need to get some greater value. And our procurement, we're teeing up our procurement to be able to think about pharmacy benefits in a much different way. Thank you.
Dana, I see your hand is up. Go ahead.
Yeah, I just wanted to respond quickly to Eileen's point. I think what we're facing now is a really challenging, like, confluence of events where spending is outgrowing revenue and we have this really tough budget target. And some of those longer term solutions that Eileen mentioned just take a while to implement, and we don't have the time right now. And so I think I would encourage the commission to consider the package on the table for this fiscal year, understanding that the governor did announce yesterday this working group really focused on affordability and getting at those core drivers, but those aren't going to be available in time to fix what we're facing next fiscal year. And last year, we ran into a situation where we needed a supplemental budget and we were running up against some really tough deadlines to making sure that our bills could be paid. And that is not a position I want the commission to be in again. And so taking action now on our benefits, while really difficult, and these are very tough fiscal times where we wouldn't have been putting together this package of benefit design changes, I think it's necessary as we move into the future and really continue to push on the cost pressures.
But can I respond to that, Dana? Because I think we know that last year there was a huge supplemental budget where about $250 million went to the hospitals. But we didn't ask for any kind of reporting or change in return. And so, like, there are other things that could be done in the budget. So I know that there's a short-term need, but part of that, I guess, is because we haven't taken the steps that we need to. And so I guess I just wonder if there's any way that some of these votes are contingent upon some other things happening, because it can't always be that we change the benefit design and kick the can down the road on some of the more fundamental reforms.
I think your head is in the same space that I'm in terms of, like, we need to really get to the core of it, or we're going to continue to have these same discussions on changing the benefits every single year for our members. And I think this affordability group that the governor announced yesterday is really the goal of it is to get at those core drivers across a range of sectors. The membership of that group is really comprehensive. They're really motivated to get moving quickly. But again, like our budget comes out in 2 weeks. And so it's just not something we have ready yet. And so this is what we're facing right now. But I agree. I think we need to keep the pressure on to get at the core drivers.
Thank you, Dana. Appreciate that. And I'll just add, I know you're part of the working group and so is Matt. I'd love to see metrics and accountability and a time frame with the governor's affordability group, because it sounds really good on paper, but if there's no action, if it's just action without metrics and results, we're in the same situation we're always in as a commission. So to that point, I see Anna has her hand up. Go ahead, Anna.
Thank you. Thanks, everyone. And I think the presentation was great, and this is a really good discussion. I just wanted to add a couple comments around like the benefit design changes that we're looking at. And in particular, like I understand that the projections of savings sort of hold behavior constant and say like if everybody does exactly what they did last year, these are the savings that we would see, right? And that's essentially just taking some of the spending off the GIC's budget and onto the member budget. But we know that when you increase, prices for things, we increase cost sharing, that people respond by using less care. And so I think these savings are, on the one hand, conservative, right? Because we expect care utilization to go down. But then I think we worry because evidence also shows that patients or members, will cut back on care that's both high value and low value, right? Like patients aren't always great at evaluating, what care is high versus low value. And so there are things that you can do with benefit design though to try to like sort of help with that. Like, and I'm thinking, you know, value-based insurance design or CalPERS has done reference-based pricing where they try to like change the copays based on the value or the prices at different providers so that patients pay less cost sharing when they, get a knee replacement at a lower cost, but equivalent quality, absolutely equivalent quality site. There's also, we think about equity and affordability. There are employers, my own employer does this where your premium contribution varies with your wages. So lower wage employees have a lower contribution. You can also do that on the copay side if we think that that would be more equitable or affordable. And so I just think that these are all things to think about. And, I'd encourage you guys to work with your actuarial consultants to I think Margaret alluded to the fact that you might expect more savings because people's behavior will change. You can forecast that and see what you expect, and that might give a little opportunity to build in some of these other things. I've done a lot of work looking at reference-based pricing, for example, and there's some positive effects there. And then last long comment, I really apologize. But the last thing I wanted to say about the copay card is I think that can really offset the burden for members, but in terms of addressing the underlying drivers, which are the high drug prices, that strategy is not as effective. In fact, like these copay cards have, in some instances, been shown to increase drug prices. So while it's a short-term solution, for sure, and I just worry about that being our strategy going forward because I don't think that addresses the long-term needs.
Thank you, Anna. Love when our health economist comes up with some ways that are impacting healthcare. So that's your job on the commission. So thank you. Toby, I see your hand is up.
Sure. I'm not sure I'm going to say anything new, except I'll certainly relieve frustration. This is incredibly unfair. You can't lay all the burden on one group. If everybody was sharing a little, then in fact, you could say, hey, you got to take your share, but it's all laying it on one group. It's the easy way out. I've heard this conversation many, many years. We got a working group, nothing will happen. And, I think we ought to think about, as a commission, maybe digging in and making some waves. Saying, what if we don't approve it? What if we don't approve it? What are you going to do? Take away my salary? So I'm just saying this. I just think that this is to get these other things adopted, really looked at, adopted. If this is insanity, that the big driver of the cost is the unit cost. That's what all the health economists tell me. We don't even address it. So that's all I want to say. Nothing new other than I just think we ought to make some waves.
Yeah, thank you, Toby. Jason, how about you go ahead and then Dean and then Bobby.
Thanks. So I just wanted to say, I completely understand the short-term need here from the state's perspective. I totally get the financial pressures they're dealing with. I'm a town administrator. I'm dealing with them on a much smaller scale locally. And we're having this very similar conversations locally. My concern is, what's long-term mean? What are the long-term solutions and what does that look like? Is it 1 year? Is it 2 years? Is it 3 years? I think Eileen was talking about this too. A working group, their work is going to take time. We don't know what's going to come out of it. And frankly, we don't know if there's going to be any support for it if something does come from it. So I know this has been said by many members already, but if we don't do something real to deal with affordability at the state level, we're just going to be back here next year, removing benefits, shifting more costs to members next year, the year after, and the year after. And that's my biggest concern, frankly. I also mentioned this to staff. I'm just going to mention it again. I would really like to see actual premium savings in dollars for individual members, just so for me to contextualize the decision. If we're increasing copays, we're seeing those numbers on an individual basis. I'd like to see the impact to premiums on an individual basis, just so I can understand and compare and contrast that. I think one of the questions on the slides was the staff was looking for some direction. Matt, you were looking for some direction on what to bring to us. I mean, the administration has asked us to reduce our budget by 120 million. I respect that request, and we have options to do that. In my view, we should consider them. I don't know that I'm going to support all of them, but I think bringing them to us for votes, I think, is fair. As a package or individually, however you think is most efficient, for us to consider them and then let the chips fall where they fall. But I do really appreciate the financial. I totally understand the context we're making these decisions, but state, local government where I am, and individual households are dealing with these issues too. And I think we need to be sensitive to that.
Yeah, thank you, Jason. Go ahead, Dean.
I'm with Toby, Commissioner, in terms of the need for the commission to really, in my view, send a strong message about this. And again, I kind of made this point before. I think the budget target is ultimately a political question. It's not just an economic question. There are ways to think about that, and there are ways to do things about that kind of, I mean, admittedly, it goes beyond the purview of the commission, but I think that's relevant to our establishment of what the context is. It's arguably a moving target. The second thing, I'm going to sort of be more blunt, is that I cannot, as the representative for the Massachusetts Teachers Association, 117,000 members who vary in terms of their socioeconomic, racial and ethnic status, that these are changes that I cannot support for the reasons I laid out. The burden falls heaviest on the most vulnerable, and the cost shifting requires the deepest sacrifice for the members that are most affected. So even in advance of the meeting, if this is what is being offered, I'm stating for the record already that these are not changes that I could support.
I think Bobby's.
All right.
I'm sorry.
Yeah, I'm getting there, Matt. Yep. Hi, Bobby. It's your turn. Go ahead.
Thank you. So I appreciate very much Toby's comments, Dean's, Jane's, and I will also state on the record, there is no way that I could support that. In fact, I agree with Toby that we need to take a stand. Our obligation is to provide affordable health care to people who work every single day, right, to benefit the public, who are out there, in some cases 24/7, and people who would be adversely impacted. It's, people of color, we know already, low socioeconomic, who are making less, people who are, as Jane spoke so eloquently about surviving spouses, right? Like what are we talking about? We're going to eliminate, coverage when we know, particularly for GLP-1s, what the health benefits are, to even think about eliminating that. And I want to mention that that almost every single year in the last 20, GIC has reverted a total of $600 million over 20 years back to the general fund. Because with the exception of last year when we needed a sup, and then I think maybe when we had the recession back in like 2008 or 2009, almost every single year, money goes back, right, to the general fund. So, why should employees, many of whom are, first of all, it's an older population, right? There were people who've worked for the Commonwealth for, 15 years, 20, 30 years. And those people are going to essentially lose because they're going to drop off. Because we are hearing for years now, as the costs shift to employees and the copays increase, right? And for pharmaceuticals and also for specialists, because majority of doctors are specialists now. People can now not afford $75 copay. And then the idea of increasing it, or the proposal to increase it to 90, it's not going to work because people will not go, and that will increase the costs, right? Because people will be sicker. They will, require more expensive treatments. And it's grossly unfair to continually shift costs. And I think that if we don't adopt these draconian proposals, I think we need to make a stand, really, because there's money to be found in other areas. I think A&F maybe should look at that instead of looking at employees.
Darren, I saw your hand up, but I did want to give Dana a chance to, since Bobby called out A&F.
Thank you. I appreciate that. I'll be brief. I think this is not the only area of the budget that ANF and the governor's office are making some really tough decisions. We are facing a significant budget challenge across the board here. This is just one agency that we're looking at right now. And so when the governor's budget comes out on the 28th, in like a little less than 2 weeks, you're going to see some really tough decisions across the board everywhere. And that's because, as we've talked about in previous meetings, when Chris Marino came to talk to us about it, we're seeing this mismatch in revenue and spend, not just in healthcare, but really across the board, that our revenue is growing ever so slightly and our cost pressures are closer to 10 to 15% and revenue is only growing 2 to 3%. And so I don't think it's a fair characterization to say that this is the only area we're looking at when we are actually making tough choices across the board. Just the purview of this commission is this particular agency. And so we don't have insight into what's happening elsewhere in the budget.
Yeah, thank you, Dana. Darren, go ahead. I see your hand has been up for a while. Thanks for being patient.
Oh, great. Thank you. So, in looking at the plan design changes that are being proposed, these are plan design changes that, in my opinion, in my, experience of over 20 years working with employers on benefit changes, these are mild. They are, I'm sorry, Bobby, I know you use the word draconian, but they're really not. In the case of, changing copays, changing deductibles, these are still, after these changes will be made, still represent a plan design that is far richer than what we see in the private marketplace. And over time, total compensation in the private marketplace hasn't kept pace with state employees. In the private marketplace, they don't have a pension. It's very rare to see a defined benefit pension in the private marketplace. Retiree medical benefits really don't exist in the private marketplace anymore. So the total comp of a state employee, I think, is actually quite good relative to the private marketplace, and in a lot of cases, under people making under 150,000, I would say it's probably richer in most cases. It's just an opinion. I don't have the data, but I haven't seen data the other way either. In terms of the socioeconomic impact, I certainly understand that, but one of the things I would point out is that, if we look at this particular slide that's in front of us, the far right-hand column, it represents premium increase. And a premium increase weighs on everybody on the plan, not just those people who have those prescriptions for GLP-1s, not just the people who are going to the doctor. It hits everybody. And those are people who, aren't really using the health plan that often. And for their increases to be borne on them because other people are using these medications isn't exactly fair either. You can look at it either way. The other thing about GLP-1s, the cost benefit analysis just isn't there. Anna pointed out some more recent data that's out there, but also the insurance company. The reason why insurers are dropping this coverage is because the cost benefit analysis isn't there for them. If it was, they would keep the coverage. But until the price of these drugs comes down, the benefits aren't there. And if companies don't make these choices and the demand doesn't drop, the price simply isn't going to drop. It's going to stay up there. So to some degree, keeping up with this and paying for these drugs is really just fueling that issue. So I think there's, these changes that are being proposed, like I said, it's still going to represent a plan that is well above that norm in the private market. We're at 92% almost on benefits paid as a percentage of total cost. It's still probably going to be in the high 80s after these changes, which is far greater than what private employees have. And there's a lot of private employees that are struggling as well. So, and they're taxpayers. And our taxpayers are looking at this, if they saw this plan and really saw it against what the private marketplace has, I think there'd be a lot of questions that the administration would be called out on. So I think our duty is twofold. And certainly when we look at our duty to the employees, I still think even with all of these changes being made, would represent an incredible plan for the employees, far greater than what they would see if they left the state and went to a private market. Thanks.
Yeah. Thank you, Darren. Anna, I see your hand is up.
Yeah, thank you. I just wanted to add on this point about cost sharing. Also, I think Darren's comments right there were really, really helpful. And I also think I think it's worth noting that not all cost sharing is bad. I think sort of this blunt across the board cost sharing might not be as effective at decreasing low value care. But if we have no cost sharing, there's overuse of care. Like that's pretty well documented. And so I really encourage our benefit design to try to like be, for lack of a better word, like smarter, and sort of use cost sharing to help patients choose higher value care, make the higher value places, lower out of cost. I think the tiered network program is like a step in this direction. And so if we can implement some of that, then people will respond because I do worry, when you have no cost sharing, there's going to be overuse, and that is also a problem.
Thank you, Anna, our health economist. Bobby, your hand, is it still up or do you have more to say?
Yes, I do. First of all, I know that Dana spoke to, she mentioned it twice regarding that this is an agency, right? These are reductions for GIC as an agency, but it's not just most reductions to agencies' budgets affect the operation. So perhaps an agency may not be able to hire people or to purchase, new laptops for their staff. But a decrease in GIC's budget affects right now like over 400,000 or over 420,000 people. It's not just the staff of a particular agency. This is a huge impact. And, some of the, perhaps an increase, in premiums, which we have talked about, is a change in the premium or an increase in the premium. Premiums are paid over 24 pay periods. It's a pre-tax deduction. It's not as impactful in a negative way as an out-of-pocket copay or deductibles are, which directly impact people and employees, right, of the Commonwealth who, frankly, are struggling with everything else that's going on in the Commonwealth, right? With the budget, with inflation, with Massachusetts being the most expensive state in which that provides daycare, right? It's the most expensive. And it's becoming unaffordable. And it's really impacting in a very unequal and unfair way to state employees. And I appreciate, the comments that have been made on the other side, but we, the commissioners who represent labor, who represent the workforce, right, are hearing something totally different. We're not looking at, I understand the cost savings perspective, but we're talking about the impact on people who work for the Commonwealth every single day. The average pension is, roughly about 45,000. The average pension is not great because people have to work literally about 40 years or more to receive, their full pension benefit. So and the average salary on average for state employees is about $80,000 a year. And you can tell me how you can live in Boston and survive on $80,000. And if you're a single parent, of which many work for the Commonwealth, primarily women, it's a huge impact on those groups.
Well, thank you, Bobby. I want to make sure everybody has a chance to have the floor. So thank you for that. I think everyone in the state is struggling. You are right. It's not a great time. Sometimes it feels like it's just not a great time to be a human. We're all struggling, and we got to find a way to come together. Dana, I see that you have your hand up. I will come to you, Dean, after we hear from Dana. Thank you.
I just want to respond quickly to something that Bobby said, and I really value your insights, Bobby. I think you bring a really important perspective here. I think when we're thinking about other state agencies, I just wanted to hit on that quickly because I think oftentimes what you're talking about there are programs that benefit taxpayers across the board. And so you're not talking about just agency operations. Yes, agency operations are a piece of it. But the other piece is what are the programs we're providing in the community? What are the things we're doing for folks to keep people out of the hospital? When you talk about mental health programming at DMH to help kids at EEC access affordable childcare through our CCFA program. So there's a whole gamut of things that are considered in this bigger bunch of agencies. And so I just thought it would be worth reminding folks of that too, that it's not just operations. Obviously, operations are a piece of it.
Thank you, Dana. You're right. You're right about that.
Yeah. There's impact everywhere, and we almost are all struggling, and we've got to find a way to fix this. And I think that's what the commission is sending, that message that, unit price, who is providing the unit price, where are the costs with hospitals, with provider groups, and there's just not enough focus on having meaningful impact there. Go ahead, Dean.
Yeah, try to collect my thoughts in a way that I could be succinct. But one thing I'll start by saying again that the budget target gap is ultimately not just an economic question, it's a political question. We could allocate money from the rainy day fund. I'm not saying that would be automatic or guaranteed, but there are ways that we could close that gap. That's one thing that I want to say. With respect to compensation and how public sector employees compare, I mean, this is true, based on the data that we reviewed, but I also want to point out that the state's contribution to pensions at about 4% is lower than what you'd see in the private sector. So if our overall compensation looks better, in some ways, that's a good thing. I'll also point out that most of us are not eligible for Social Security. So the sort of the fairness and value of the overall compensation package, I think it's more nuanced than might initially meet the eye. The last thing I'll say is that in light of the fact that we are going to embark on a full review of affordability, I would urge commissioners to hold off on these kind of plan design changes to make the case for holding the line as it is right now until we have fuller menu of data and not data, fuller menu of policy directions that we might go to get at the structural drivers of increased costs of healthcare. I mean, Massachusetts per capita is the second most expensive in the world. And that is a fundamental economic constraint, if you will, that we really need to address.
Thank you, Dean. I see, Tamara, you have your hand up. It's nice to see your hand up. How are you, Tamara?
I'm well, thank you. Thanks, Valerie. I was wondering whether or not we might think about this in a somewhat different way. And it's in order to show some equity, and I guess GLP-1s are major budget buster here. Is do we have the data to know how many of our members are, let's say, assuming Bobby is right that the average salaries is around 80,000, and I don't know whether that's true or not, but I'll believe Bobby. If that's correct, then can we somehow be able to subsidize some of the GLP-1 costs for those below a certain salary? In other words, if you need it because of your economic condition, because of your socioeconomic level, and you're not receiving a salary that is, above average or whatever number we choose, then we will support some of the GLP-1 costs. Otherwise, we don't support the GLP-1 reimbursements. And I think somehow, and I totally agree with Darren in that there is so many people, and we don't know what the percentages are of those that are making over 80,000 or 100,000, whatever number you consider as being socioeconomically viable. And how many of those are carrying the cost for everybody else? And it could be the lower socioeconomic level could be high or it could be low. I don't know. So I'm wondering if there's any way to connect what we're trying to do with the for those that really need it because of their socioeconomic levels, that we would be able to provide them possibly a different cost structure than those that can afford it. And I know somebody has to pay for some of this, but there's a way of looking at it in a somewhat different way. And I don't know if that's feasible, but that's just an idea that I thought I'd throw out there to think about in an innovative way of how we could address this issue.
Yeah, I love it, Tamara. I think you've heard potentially from me. I am looking for more innovation, more out of the box thinking, more data oriented decisions. And I would love to get those numbers, as you said. So, Bobby, I see your hand is up. I also see Darren's is up. Is there new comments you're making?
Yes, I am making new comment, which is that
succinctly, please. Succinctly.
Yes, since Vita, we just launched Vita, I'd like to, see what the savings might be from them. I mean, they're really new. We don't know yet. We don't know what, whether it's going to be successful or not. And to see what those savings might produce, right?
Yeah, I love it. I agree.
And I appreciate Tamara's, comments about looking at it, trying to figure out like some other ways to look at, this large problem.
Innovation, out of the box thinking, would love to see it. Really needs to be done. So go ahead, Darren, you will have the last comment.
Oh, that's a lot of pressure.
I know, right?
No, I actually, so Anna had brought this up earlier. I think, Tamara, you had just mentioned it. I think you were talking about the same thing in basically having a scale based on earnings, what you would contribute to the health plan as an employee. And I always referred to this kind of candidly as the Robin Hood model. You're basically having people who earn more pay more towards the health plan. My question is, and I love these models, they're very common in the financial services industry, but not a lot of other industries. It's really kind of spotty after that. But I think what my question would be, would that require a legislative measure as opposed to something the commission could do?
There's a number of different considerations that would warrant a longer discussion on how to do that. Likely would need some legislation depending on how you structure it. So for instance, if we're talking about premium contribution ratios across the board, that of course would need that would need legislation. I think we also need to consider, the state has information about state employee salaries. It doesn't have information, I guess we'd have to explore this, around family income, right? State has employee income, but not family income, spousal income, that sort of thing. So
Yeah,
this
total
notion
household.
of kind of income graded benefit design, I guess for lack of a better word or phrase, is something that we've explored in the past. It is deeply complex, but we do have an interest in it. So thank you for that suggestion.
All right. Well, I love that we had multiple commissioners weigh in, so super engaged, and appreciate everyone's openness to listen to each other, to use that information to inform our thinking, to be balanced in the needs of the Commonwealth and those who work for the Commonwealth, and all taxpayers. That is our fiduciary, to be as balanced and thoughtful and data oriented. So I feel like this was a good discussion. Thank you, Matt, Margaret, the whole team that's behind the scenes working very, very hard here at the GIC. So at this point, I'm not seeing any additional comments, questions, or business. So I will entertain.
Could I make one comment?
Yeah, sure, Jason.
Thank you. I just have a quick question about just a general question about board governance. So I've been here for like 2 years, believe it or not. And we haven't like organized as a board. I just didn't know what the rules, bylaws, etc. were in terms of process, timing of the board electing their leadership. And that's no reflection on the current leadership, but locally, we usually have like reorganization meetings annually. So I was just curious how that works here.
Yeah, our bylaws do not have reorganization mandates on an annual basis. We redid the bylaws. It's probably been about 7 years now, so I would need to dust those off, and I will.
Okay.
And we'll get back to you.
Thank you. Appreciate it.
Yeah, we can share. We really should share the bylaws with the entire group, and we'll do that as a follow-up to this meeting.
Yes, so thank you for bringing that up. Appreciate it. Do I have any other follow-up comments? I love the input from all the commissioners. I really believe it makes us a stronger group and more helpful to the staff and to ANF when we are all engaged and commenting and driving the changes we want to see. All right. Well, no one else has a comment. Thank you for speaking up, Jason. Thank you to all of you. And at this point, I will remind you about the public information sessions. So please register for one of them. I know the staff will be sending out a chance for you to register for one of these live stream. And at this point, I will entertain a motion to adjourn.
So moved.
Second.
Jason first, Toby second. So all in favor, just a group I.
Aye.
Aye.
All right. Have a good rest of the month, and